All right, welcome to this explainer. Today, we're doing a bit of clinical detective work to unravel a notoriously challenging medical mystery, the classic surgery long case. We're going to use a highly structured, investigative framework to navigate this from the very first patient symptom all the way through the diagnosis, the prep, and finally, the complex surgical treatment. If you want to really understand how doctors piece together the puzzle of pancreatic cancer, you're in the exact right place.
Picture this. A patient walks into your clinic, and they present with this exact clinical picture. 4 months of progressive, painless jaundice, alongside a distinctly palpable gallbladder. That is a striking combination of symptoms, and honestly, it should immediately set off alarm bells for any seasoned clinician. Okay, let's dive into this, because this specific presentation is the ultimate hook. It's the starting point of our investigation, and it points us directly toward a critical, urgent diagnosis that we absolutely have to confirm.
Here's our roadmap for solving this case today. We'll start with the clinical picture, move into gathering the evidence, discuss preparing for surgery, break down the Whipple procedure, talk about managing unresectable disease, and finally wrap it all up with an exam summary.
Section 1. The clinical picture. Let's start phase 1 of our detective story and listen closely to what the patient's body is telling us.
So here is our full suspect profile, if you will. The patient isn't just yellow. They've had progressive, painless jaundice for 4 solid months, accompanied by dark urine, pretty significant weight loss, and anorexia. But look at that last detail, fever with chills and rigor. This isn't just a tumor slowly growing in the background. This specific symptom strongly suggests ascending cholangitis, which is an infection of the bile ducts. It's a critical, life-threatening complication that takes our chronic mystery and turns it into an acute emergency.
Now, what's really interesting about this is the classic medical eponym involved here. Courvoisier's sign is an absolute aha moment in clinical diagnostics. When you feel a palpable distended gallbladder in a patient who has painless jaundice, the underlying cause is highly unlikely to be gallstones. I mean, think about it. Gallstones usually cause a shrunken, fibrotic gallbladder, and they really hurt. Instead, this sign points a giant, flashing neon arrow right at a malignant obstruction. We're most likely dealing with a carcinoma sitting right at the head of the pancreas.
With our primary suspect identified, we move to Section 2, gathering the evidence. We need the hard, undeniable proof to confirm this suspected carcinoma. We always start by drawing blood. For the general workup, we're checking a complete blood count, blood sugar, and a liver function test, or LFT. The LFT is absolutely crucial here because we expect to see elevated bilirubin, mainly direct, along with elevated ALP and GGT. Those specific enzymes actually confirm the obstructive nature of the jaundice. We also have to check their clotting profile, the PT/INR, and their renal function. Then, we hunt for the specific fingerprints of the cancer, using tumor markers, specifically checking for elevated levels of CA19-9 and CEA. Let's move to the imaging strategy and see how this builds. We don't just jump straight to the most expensive scan right out of the gate. Step 1 is our first-line defense, a whole abdomen ultrasound. This gives us a quick confirmation of dilated bile ducts and a distended gallbladder. But to really see the tumor itself, we need Step 2, the CECP abdomen, specifically using a pancreatic protocol. This right here is the gold standard investigation of choice because it tells us the exact size of the tumor, checks for any vascular involvement, looks at the lymph nodes, and spots any liver metastasis. Finally, for Step 3, if we need absolute tissue proof before proceeding, an endoscopic ultrasound-guided FNAC gives us the biopsy.
Section 3. Preparing for surgery. We have our evidence, but you cannot simply rush a fragile patient like this straight into the operating room. This phase requires some serious, multidisciplinary preparation.
A major pancreatic surgery is incredibly taxing on the human body. We literally have to stabilize the patient first. We've got to correct the effects of the obstructive jaundice, which might mean giving vitamin K injections or fresh frozen plasma if their blood isn't clotting properly. And remember that fever and chills we talked about? We must aggressively treat that active cholangitis with IV antibiotics and fluids. We also need to build up their strength with targeted nutritional support, like a high-protein diet, correct any anemia, manage their electrolytes, and, if indicated, perform a preoperative biliary drainage using an ERCP stent. We have to relieve that pressure in their liver before we even think about making an incision. Once stabilized, if the tumor is deemed resectable, we arrive at Section 4, the Whipple procedure. This is our surgical solution, and it happens to be one of the most notoriously complex operations in all of general surgery. And this brilliantly illustrates why it's so complex. The sheer anatomical scale of what the surgeon has to do is massive. Because of how tightly intertwined the blood supply and the anatomy are in this specific region, removing a tumor at the head of the pancreas isn't just a simple excision. The surgeon actually has to remove the head of the pancreas, the entire duodenum, the distal bile duct, the gallbladder, and often a portion of the stomach too. It is a massive rearrangement of the patient's digestive real estate. But taking those organs out is honestly only half the battle. Now the surgeon has to meticulously plumb the entire digestive system back together so the patient can actually process food. They perform a pancreatico-jejunostomy to connect the remaining pancreas to the small intestine. They do a hepatico-jejunostomy to connect the remaining bile duct, and finally a gastro-jejunostomy to attach the stomach. It's an incredible, painstaking feat of surgical engineering.
Unfortunately, pancreatic cancer is very often caught late. That brings us to Section 5, Managing Unresectable Disease. We really have to acknowledge the gravity of this disease and understand the treatment paths for when the tumor cannot simply be removed.
We categorize these challenging cases into two distinct paths. If it's borderline resectable, meaning it's tangled up in blood vessels but hasn't spread far, we use neoadjuvant chemotherapy or radiotherapy to try and shrink the tumor down, and then we reassess to see if surgery is now possible. But if it's truly unresectable or metastatic, our goal changes entirely. So, the crucial point is understanding this pivot. In metastatic disease, we shift away from attempting a cure and focus entirely on palliation. We're looking at relieving symptoms and extending the quality of life with systemic chemotherapy.
Palliation is all about compassionate intervention. To relieve the unbearable itching and liver damage caused by jaundice, we can place an ERCP biliary stent or perform a surgical bypass. If the tumor happens to be blocking the stomach from emptying, we can perform a gastrojejunostomy just so the patient can still eat. For pain relief, which can be incredibly severe in pancreatic cancer, we use strong analgesics or a really specialized technique called the celiac plexus block, which effectively numbs the nerves transmitting pain from the abdomen. And finally, systemic chemotherapy is used to slow down the overall disease progression.
All right, we've covered the entire clinical journey. Now, for all the students and residents tuning in, let's jump into Section 6, the exam summary. Here are your absolute high-yield takeaways.
If you're facing a surgical long case exam, this is your classic 5 + 5 + 5 breakdown. For your 5 marks in diagnosis, you want to confidently state carcinoma head of pancreas, causing malignant obstructive jaundice, making sure to highlight Courvoisier's sign and cholangitis. For the 5 marks in investigations, rattle off your bloods, your CA19-9 tumor marker, and definitely emphasize the CCT abdomen on a pancreatic protocol. Finally, for the 5 marks in treatment, split it up clearly. If it's resectable, it's the Whipple's operation. If it's unresectable, it's biliary stenting, bypass, chemotherapy, and pain palliation. You definitely want to lock this framework into your memory.
And that brings us to the end of our investigation. We've successfully traced the path from a silent, growing threat to a complex surgical masterclass. So I'll leave you with this thought. Next time you're on rotation and you encounter a patient presenting with painless jaundice, how quickly will you piece together these clues? Recognizing Courvoisier's sign early could literally be the key to changing a patient's entire clinical journey. Stay curious, keep investigating, and I'll catch you in the next explainer.